Hey everyone, it's a dose of Dr. Drew.
Hey Troy, you were first. Hi mommies. Let you guys pile in here. At the very top of the restream, you will see a lot of information about the organization we're highlighting today, which is the Urban Resource Institute. They work in New York City and they find safe, secure housing for individuals and families, including their pets. They respect their rights, make informed choices. The donation will immediately help purchase food, personal protective gear, N95 masks, disinfectants, clothing supplies, soap, sanitizer. It's all in the top of the restream there, all that information. It's in addition, hundreds of youth living in the shelters. There are enrolled in school. So there's a lot. Victims of domestic violence is one of the greatest resources in New York City. And of course, they are stretched right now too, as well as everybody is. You can call them if you need a safe place at 800-821-HOPE or 911, of course. And for more information, you can call them about COVID-19 at 866-364-3065. But more importantly, we have a GoFundMe set up at drdrew.com/URINYC.org. Again, you can make deductible donations there.
No, it's just URINYC.
No .org?
No .org.
Okay, drdrew.com/URINYC for the Urban Resource Institute.
I don't know why it says .org on there. That
Mistake. But again, they even well before this epidemic, they're one of the greatest resources for people, victims of domestic violence, people who are having difficulty with homelessness. It's a lot to be done, as well as at-risk youth. They do a lot at URI, so please help them out. They are obviously stretched thin, as is everybody. I see you guys piling in. Thank you all.
I try so hard to be right, and I make mistakes.
It's all right. A little COVID update. Looking at the data at the University of Washington, we are one day to a peak for the United States, meeting our resource needs by these predictions. They are at this point, our death rate has fallen a bit. They're predicting that we are now passing the peak per day death rate and a total of around 60,000, which we're hitting right at the beginning of May. So hopefully those are even inflated data. We're going to talk to a doctor in just a few minutes that will give us some hope that the novel improvisations that so many doctors are engaged in are helping save lives. And I think that's what we're going to see in the next few days is the dramatic effect of what physicians are doing to reduce hospitalizations, reduce ICU use, get people off ventilators. Let me just tell you, in California, we apparently are a week or so away from some sort of peak here in LA County, but I don't know where they're getting that data. I'm interested to find out. The peak in California is predicted to come in 3 days, and we will meet our resource demands. And the death rate has dropped suddenly in California down to 49 per day. Hopefully that is a trend that will continue, though it's not predicted to do so. So we're only at about 500 deaths in California in a state of 30-40 million. So I would say California has done remarkably well. So it is at this point I want to bring my guest in. He is the Director of Intensive Care at Providence Cedars-Sinai Tarzana Medical Center. He's been treating a lot of these patients, and he has some really interesting insights into what this thing is and what doctors should be doing about it. His name is Dr. Thomas Yadegar. Dr. Yadegar, thank you and welcome to the program. Susan?
Hi, Dr. Drew. Thank you for having me.
There you are. So when did you first start seeing these cases?
It's been probably about a month. Early in March is when we first started seeing the patients.
And you had told me last time we spoke that even when you were getting to the cases late, they were already on ventilators. You've had great success in saving lives and getting people off.
Yes, we have. It's actually been going really well the past few weeks. Initially, when we started seeing the patients, there was a few patients, and this is common for any of the frontliners that are taking care of these patients. Patients come in, they're really not that sick. Everything that you've trained and everything that you've done, tells you that, no, this patient will probably do well. And of course, that turns out to be not the case. Within a very short time, the patients become unstable. All your typical blood tests, all the typical x-rays that you do really don't help you at all. And before you know it, the patient ends up on a ventilator and you have no idea what just happened to your patient.
Now, one of the things I'm reading is that there's a movement to try to keep people from the ventilator. Is that your feeling too? Do everything you can to keep them off, because that seems to be exacerbating some of the ARDS, or at least the complications of it?
Yes, there's a lot of literature citing whether if you can keep them off a ventilator, they may actually do better.
Right.
The other reason is to keep them off a ventilator is usually when they go on a ventilator, they could be anywhere between 10 to 20 days. And with all the shortages of ventilators and everything else that's going on, if you can prevent a patient from going on a ventilator, then you've done some real benefit.
And even again, back to how physicians are improvising now, sort of CPAP machines and all kinds of other things other than a ventilator to keep people off. Are you doing that?
Initially when we were discussing treating COVID patients, there was a lot of talk about trying to not cause any aerosolization, which may put the nurses and the healthcare workers at risk for acquiring the infection. So initially, everyone was trying to stay away from it. I think at this point, we're experimenting more with it and trying to see if we can do rescue non-invasive ventilation, which would be, put them on CPAP, put them on something like BiPAP, and then try to avoid them going on a ventilator.
Now, the area in which you've had really great results is working on something that New York Times reported on this morning, and people are starting to hear a lot about, this so-called cytokine storm, which is this activation of our immune system by the virus that literally causes, protein, weird and unusual immune attacks on the body. Talk to us about that a little bit.
Yeah, I mean, from my standpoint, that was really the turning point for our group when we started looking and developed it. There's a thing called cytokine storm syndrome. It's not something that's very common. In my 20 years, maybe, I've dealt with it a few times, but it's pretty rare. It's pretty elusive. Although typical lab tests and x-rays don't really help you to diagnose this disorder. And again, it's such a rapidly moving disorder that if you're not thinking about it and you're not treating your patients for it, before you know it, they'll end up on a ventilator.
And by treating it, we're using these novel new medications. And whenever you watch TV right now, you'll see Humira and all these new medications for rheumatic diseases, inflammatory diseases, and these are now being deployed for this inflammatory reaction triggered by the virus. Correct?
That's correct, and the treatment is pretty counterintuitive. Normally in the ICU, I want my patient's immune system to be strong. I want it to be active. I want to make sure that they fight off infections. But in this case, for this syndrome, to heal your patients, you have to give them very, very strong medications to suppress their immune system.
And we do that. I mean, we use the mallet of Solumedrol. We've used it forever in various settings, and it's been studied in sepsis. It's used in pneumonia. We've always had a sense that there was something about hyperimmune activation in systemic illness that we should be paying attention to, don't you think?
I think so. And, from my practice, from a pulmonologist, I mean, Solumedrol, prednisone, those are medications that I use commonly to treat patients with asthma, to treat patients with COPD. And there are instances where we give it in the ICU as well. But in this case, to suppress the immune system, you do have to give these types of medications, which are used in, rheumatoid arthritis and other types of rheumatological disorders. And also, depending on the stage of the cytokine storm, you may not get away with just giving one. There's been instances where I've had to give 3 different types of medications to suppress the immune system.
And it's worked.
And it has worked, yes. Since we developed the management guideline and we implemented it, we actually haven't had a single patient that has required to go on a ventilator. And every single patient that we had on a ventilator, we've been able to get them off.
That is amazing. Are you keeping people out of the ICU with these things as well? Or is it only really for people that end up in the ICU?
Yes, the ones that are admitted to the floor, we're watching them very, very closely. We're watching the relevant serum markers. And again, the hallmark of this disease is to find it early and to treat it early. So if they get it, if you're not looking for it and you're not treating it, they're going to end up in the ICU, and then you're going to be, behind the 8 ball again.
And are other doctors arriving at similar sorts of protocols, do you think?
I'm starting to talk. I've been talking to a lot of my colleagues, and I think they're still looking at elsewhere. The syndrome can cause a lot of different manifestations.
Yeah.
So one of the common ones is coagulopathy. So there's a lot of doctors that think it's a coagulation disorder and are treating patients with anticoagulants. It's challenging. It's a difficult and challenging diagnosis. Otherwise, I think a lot more people have already come up to it.
Right. Have you seen any utility from the strong antivirals, or is the virus already clear by the time we get the cytokine storms?
Initially, we were using the retrovirals that we use for HIV medication, HIV patients. I didn't have enough experience, but the patients that were on it didn't really seem to do very much. I suspect that by the time that these patients come to us, it's really the cytokine storm and not necessarily the virus itself that's causing it.
Again, I wonder if you could talk a little bit also about the different pulmonary manifestations. You had told me once that it looks like everything. I just dealt with a patient this morning that had a lobar pneumonia. I thought for sure it was bacterial, ended up being COVID.
Yeah, I mean, there isn't anything that this disease can't do in the lungs, it seems. The other weird and unusual thing is that, when patients end up on a ventilator, there's a wide range in terms of what we consider their compliance. How compliant is the lung?
Right.
So some patients are very, very compliant and they have problems with oxygenation only. Other patients are much less compliant and they have problems with not just oxygenation, but also their ventilation and their carbon dioxide.
Any theories about the predisposing issues in complication? I've noticed, there's a lot of ink spilled about diabetes and hypertension and, the sort of chronic medical illnesses of the lower socioeconomic end of the ladder. But when I see pictures of patients that get into trouble, they're always obese. And not always, but a lot of obesity I'm seeing. And I'm wondering if maybe obesity is really more the issue. And when you think about it, we always talk about how adipose tissue is an inflammatory organ. Maybe that somehow is part of what is being activated.
It's entirely possible, Drew. To be honest with you, I actually think almost everything has a genetic basis for it.
Yeah.
In this case, I think the virus is just triggering your immune system. And if you're one of those unlucky persons, because it doesn't happen in every patient with COVID-19, it only happens in a small subset. But if the virus activates your immune system, then, you're going to go into the syndrome. And unless someone figures out what's going on with you and, gives you the right medications to end the syndrome from progressing, you're just going to progress and eventually develop respiratory failure and need a ventilator.
I'm watching the restream here, and Serena made an appropriate observation. She said, well, the Chinese didn't have obesity. No, they had smoking. They had cigarettes. So we have obesity, they had cigarettes. And those, and by the way, some new data on cannabis this morning, even mild, occasional cannabis use seem to work against you in terms of risk of complications. So there's the lung issue with the lung and the tobacco and the cannabis, and there's the systemic cytokine issue with the adiposity. I think, again, we're all, trying to put the pieces of the puzzle together, right?
Yeah, I mean, there's many different factors, and I don't think we're ever going to find one determinant that's causing everything. The other thing about the cytokine storm syndrome is that it's what we call a diagnosis of exclusion, which means you have to think about every other disorder or every other disease that could be causing something, whether they have a bacterial pneumonia, whether they have sepsis. You have to evaluate and make sure that that's not what's causing your patients to require a ventilator. And then you have to think about cytokine storm. And once you think about it, you got to look for it and then treat it aggressively.
Yeah, I think our peers are starting to think this way. It's interesting how everyone is just sort of developing a collective understanding slowly as they improvise and try to manage this thing. Again, I talked to a rheumatologist this morning, and I started yelling at him about, where are the rheumatologists? Get into the ICU. We need the rheumatologists. These are your meds that you use all the time. And I did a fair bit of rheumatology back in the day and treated a lot of vasculitis. I treated polyarteritis nodosum. I treated a lot of temporal arteritis. I treated small vessel leukocytoclastic vasculitis. So I got used to that world of the rheumatologist, particularly when it comes to their systemic inflammatory disease. And they're all very subtly different, and of course their biologies are different too, and they require different approaches. And it's not a pulmonologist or an intensivist game. It's the rheumatologist has the sensibilities on this. Have your rheumatology friends helped you with that?
Yeah, I mean, I think it's a great idea, great point that you raised. And yes, I've actually been very fortunate. One of my friends, Dr. Boris Ratner, is a rheumatologist in the area, and he's actually been incredible. Again, these are not medications that I had used in 20 years. If you came to me a month ago and told me I was going to give patients in the ICU very, very strong immunosuppressive agents, I wouldn't believe it.
Well, you wouldn't understand. You wouldn't understand what you'd be trying to figure out why. Like, why would I be doing that? It doesn't make sense. But here we are.
Right. Of course, it's very counterintuitive.
Yeah.
But no, doctor, I've had incredible support, and I got a crash course in all these types of medications, and obviously we were limited in what was available in our hospital. I'm looking forward for all the well-controlled randomized studies that are being done, and hopefully, we can come up with some sort of a protocol that makes sense.
Yes.
But from my experience, you have to think about this disorder, and you have to treat it early and aggressively. Waiting till the last quarter and trying to do compassionate care, that's just not going to work.
Andy Shen, that is true about rheumatology. That's kind of what I was complaining. We need to get them into the hospital, that their domain is in the outpatient. And Oslo, Dr. Yadegar, I'm watching a thread here of people commenting as we speak. And Oslo, Jessica, congratulations on the no smoking. Well done. So let's see. I've got so many questions. Let me see if I can think about what I wanted to talk about next. Oh, I guess hydroxychloroquine would be the next topic. And do you think that the mechanism of hydroxychloroquine is perhaps going at the same phenomenon we're talking about today?
Well, it does have anti-inflammatory properties. So I think, and a small subset of patients that I've been tracing do actually do well, and it seems like it does help. I just think it has to really do with how hyperactive your immune system has gotten.
Right.
If it's just mild, hydroxychloroquine may be enough to prevent it from progressing. But if you have someone who has, severe activation, very, very overactive immune system, it's probably not enough, and that's why you need to give the other medications.
Are there physical signs or manifestations of when this gets going? In other words, are you just looking at laboratory tests, or can you actually see skin changes or anything else you can look at, or hemodynamic changes?
No, and that's the part that's so elusive about it is there's no real physical exam findings, and even the lab findings, the normal ones that we check for, are not really helpful. So if you're looking at a white count going up, if you're looking at the lactic acid going up, that's usually not the case. One of the early hallmarks is just the increase in oxygenation. So even going from needing 2 liters, which is not a lot, to 4 or 5 liters, which is still, from our standpoint, not a lot. But from my experience, 5 liters is that's where you're borderline. If you let them get above that, then you have a good chance that the patient's going to end up on a ventilator. So we try to initiate therapy before they get to that stage, and again, we've been successful, and we haven't had anyone require intubation over the past few weeks.
I was in a symposium with some of the Italian doctors during their experience, and they actively avoided these kinds of improvisations. They strictly went towards supportive care, and they defended that as something that they do well, and therefore that's all we should be doing. And as we now know, the supportive care is the ventilator, and that is a mixed bag. Once you get to that point, you want to avoid it because the complications start to go up immediately, right?
Of course. I mean, once you put a patient on a ventilator, never mind what's put them there, but once they're on a ventilator, now now they're at risk for developing, nosocomial or healthcare associated pneumonia just from the ventilator alone. So now they're at risk for other types of things and getting blood clots and being in the ICU for 10, 14 days. You're going to get possibly urinary tract infection.
Right. So
now,
there's
you have a whole bunch of other things you have to deal with.
Right. You get blood clots in your legs that develop into pulmonary emboli. You get what's called barotrauma to the lungs, just the pressure of what's being pushed in there. There's pressure of high flow oxygen damages the lungs. So I mean, and it's an open tube now from the outside world into your lungs, and so bacteria can get right on in there very easily. And that's what Dr. Yadegar was talking about, the nosocomial infections, which are very common on ventilators.
unfortunately, they are, and that's why, again, one of the things that we always fear when a patient's in the ICU is infections, and that's why it's so difficult. And I think that's probably why a lot of the clinicians that are treating these patients have a real hard time, to give them the strong immunosuppressive medications that they need.
Right.
And again, you're right. This is a rheumatologist, place.
Yeah.
Pulmonologists and critical care doctors. This is not something that we.
No.
Yes, we give Solumental all the time, but
right.
But to take it 2 steps further, that's somewhere it makes us very, very uncomfortable to have to do that.
Well, it's like anything in medicine. You gain a sensibility about it. You get an instinct with it. You have an experience with it. You have a wisdom with it. You kind of, right now, as you and I sit here, I don't think either of us could really talk about the nuanced difference between a leukocytoclastic vasculitis and an ANCA-associated vasculitis and a polyarteritis nodosum. We know they're different, but we don't have enough experience with them because we don't see that every day to be able to go, oh, yeah, this is definitely not that. It's this other thing, and this other thing responds to these particular immunosuppressants. That's what I'm missing from rheumatology right now. I wish they would. I'm hoping they're getting involved somewhere because they could really, really kind of contribute protocol, it seems to me. The other thing...
And I would disagree with the Italian...
Go ahead. The Italian?
I'm sorry. I would disagree with the Italian experience. While I concur that you shouldn't just start, throwing different medications at patients. And to me, it seems like we are doing some of that. I don't think there's anything wrong with if you find out what's wrong with your patient and you're doing novel therapy to treat those disorders.
Yeah.
I think that's different than, just kind of shooting at the hip.
I completely agree with you. And I brought up that Italian physician because I think it was wrong. I think it's why they got into such trouble and why they had such shortages of resources, because they put everybody on the ventilator in the ICU and no one was getting off, no one was getting better, and they were not thinking.
Right.
Humbly, I know they worked very hard, but it was not the kind of thinking you're doing right now. The kind of really careful improvisation around what we're seeing clinically and what we think is going on biologically. I think that's what I know how physicians are, and talented physicians are in this country. I knew they would come up with novel solutions. I just knew it. And my question to you is, do you think that these novel approaches that we're gaining some skill with now is going to impact the daily death rate? Like we'll see that measurably get into the data soon?
I want to say yes, but I think unless it is implemented nationally and on a larger scale, it may not be. I don't think enough people are doing it and initiating it early enough and aggressively enough to make a huge impact. A lot of the physicians I talk to, a lot of the physicians that work with me, I've been, it's taken me 2 weeks to get them to this point, and even then, they're still kind of hesitant to be fully aggressive and to give the medications that the patient needs.
Have you seen? Is there a reason other than lack of familiarity or not being familiar with it? Or have you seen any real bad reactions?
I have not. I have not seen any real bad reaction. And I think the main reason is that since there isn't a way to make a definitive diagnosis, so there isn't a single lab test or there isn't a single x-ray, and it's, again, like we talked about, the diagnosis of exclusion. It makes a lot of physicians uncomfortable to give these types of medications when they don't have a definitive diagnosis.
Right.
And that's what I hear all the time. Well, how do you know it's this? How do you know it's this? And my answer to them is, okay, it isn't anything else, so give me an answer to what is causing this.
Right.
And if there isn't anything else that's causing this, then you can't tell me that this isn't causing it. And I think also, unfortunately, in nursing, in medical school, some of the critical thinking that needs to be there is kind of, isn't emphasized as much. It's a lot more kind of protocol driven and standard of care. And, that definitely has its place. But we as physicians, we as nurses, we need to do critical thinking because there's nothing in medicine that's routine. And, especially dealing with this virus, this is a very, very, very tricky virus. And you have to be on your game every second of the day. And just when you think, oh, okay, I understand everything, it's going to trip you up.
Yeah. What was your undergraduate training in?
My undergraduate training was in biology.
Yeah. I feel your biology training. Where did you train?
I was at UCLA for undergrad, and I was at USC for medical school.
Great. Well, the biological training, it's serving you because it makes you think about the biology constantly. And I have a similar background, and it's just I can't think any other way right now. And so it's helping. It's helping to try to make sense of this whole thing. Well, do you know anything about what's going on in LA County? This isn't for just us here locally, in that the LA County officials seem very frightened about the next week in terms of there being some sort of surge, or at least the next 2 weeks. And I just don't see any data. I mean, we are certainly, we're up at about 88,000 cases in a catchment area of 10 million. I would call that a triumph. Is there something going on that they're seeing a sudden spread or some outbreaks that we don't see yet in the data?
Not that I'm aware of, but to be honest with you, the last thing I have time for is to keep up with anything. I'm working to take care of the patients, and then also train all the doctors, to hopefully be able to take care of the patients. The one thing I would say, though, that's pretty consistent is this disease seems to move in clusters.
Yeah.
So 3-4 weeks ago, when we started seeing a lot, I called my neighboring physicians in other hospitals, and they weren't seeing any of the COVID patients.
Right.
We've kind of tailed off, and we actually are not very busy. But then now those hospitals are much busier than we are.
It's interesting.
So I don't think there's any consistency. It just seems like there's an outbreak cluster in different parts of the city. But I'm not sure that we're going to have a massive increase in every city.
Right. And
in
the
every
way,
section of the city.
I agree with you. And the way, you only need about 3 of these patients in your ICU to feel busy. You know what I mean? These are, having this kind of challenging case.
For sure.
So people are going to, we're not talking about 30 cases to feel busy, though some people may get stuff like that. Well, listen, I will let you go. I know you got to get out of here and get back to work. Is there a website or anything else you'd like to refer people to?
There isn't. I'm working on something to try to hopefully educate physicians a little bit more, and and educate patients. But for now, I think again, listen to our local representatives. Please stay inside. Please continue to practice social isolation. The one thing I would say though is that we have seen an increase in the number of patients that are coming into the emergency room. In very, very critical condition. No, I'm not talking about COVID now. So patients that have pneumonia, patients that have a heart attack, they're waiting too long. Everyone, I think, is afraid of coming into the hospital to acquire COVID, and for things that are routine and they should be coming in, they're waiting and they're not doing it anymore. So, I would say if you have an emergency, don't stay home just so you don't want to acquire COVID. Yeah. If you have an emergency, still come to the hospital. We will take care of you. We will do everything in our power to make sure that you're isolated from those patients. But please, listen to your healthcare providers and follow the directions, and don't be afraid to come to the emergency room.
Yeah,
room if you need it.
That's a not okay consequence of all this. If you're having chest pain, you go. If you're short of breath, you go. If you're having neurological symptoms, you go. And if there's any question, you go. And if you're not having respiratory symptoms, you will be taken away from the respiratory folks. So you don't have to worry about the exposure. Pretty much everyone has got this down now, where they are being very cautious with exposure of anybody coming in. Thomas Yadegar is the medical director of the intensive care unit, Providence Cedars-Sinai Tarzana Medical Center. That's where he works, and that's where he is coming up with these novel ways of saving these patients. And I really appreciate you, Tom, spending a little time with us here to talk about your experience. And I hope other doctors are listening, and I hope there are similarly critically minded, critical thinkers out there that are applying novel techniques to try to make a difference, because it is making a difference. That's the important thing. We are not just leaving people on the ventilators, we're getting them off. So hopefully I'll get a chance to talk to you soon, okay?
Thank you so much, Dr. Drew. You be well.
You got it.
Stay safe.
Good luck. Take care. Okay, let me look at the restream now while you are all Any questions you guys have, I'm happy to get. There's no way to follow him. No, I'm sorry, Jolene, but I'll try to report on his progress. I'm in communication with lots of different doctors now from lots of different areas. And I just thought it would be interesting to expose you to kind of why we're having, I think Dr. Yadegar is an example of why we're having success here in the United States, where these critical care specialists are improvising and coming up with novel approaches. They're thinking about it carefully, and they're applying techniques that are working, and they're being very, very, very cautious about it. Can I explain what a novel technique is? Meaning these are therapeutics we did not think of using before COVID. These are novel in the sense that they're new and they're different from the way we would normally approach things. But they make perfect sense given what we think the biology is going on here. It's just, that's it. Can I speak on herd immunity? Aaron is asking. Stanford is doing a big study in Northern and Southern California to try to understand why California is doing so well. One of the theories is that because we had thousands of people directly flying from Wuhan every day in December and January, that we maybe developed some herd immunity here. So that data should be soon, I hope. All right, can I explain again hitting our peak means? Meaning that's the peak number of resource need, peak number of ICU beds need, and then peak number of deaths per day. That's what we mean by hitting the peak. No, Malarone does not work the same as hydroxychloroquine. It's different. I don't think anybody's studying that. And Malarone, I'm not sure if that's a daily medication so much. It's something you don't be taking a lot of. And it's another malaria medication. Metformin and zinc, that has been discussed, is being discussed out there. I have no opinion about that. Zinc does seem to have some utility. It's being combined with the hydroxychloroquine. Let's see. Am I talking about, I don't know what you mean about the mice. Please tell me more what you mean about that. The peak date for Massachusetts. Yeah, I'm worried about New England, I got to tell you. Our next challenge is going to be Massachusetts and New England. The peak for, I've not looked at it since they adjusted the data. It looks like you're going to meet your demands, but the peak is going to be April 27th at about 8,000 beds. 17 days till the peak of deaths per day, but that will remain pretty low relative to some other states, but not that low given a state that size, with about 6,700 deaths overall. So it'll be interesting to see with all your academic facilities out there, will they make a death in that ICU rate and that death rate? I'm going to bet they do. Connecticut is, of course, getting people bleeding over from New York City. Everyone who works in New York City lives in Connecticut. They are peaking around April 25th. They also have about 2 weeks before the peak in their daily death rate. Their rates are still low in Connecticut, but they're predicted to climb. Let's see how that plays out in the next couple of days. If that starts getting adjusted down and the hospitalizations get adjusted down, that tells you that these therapeutics that doctors are using are really working. That's what to look for next. And New York is already on the downslope. New York is on the other side of its peaks. It's coming down in all areas. And the way something called Farr's Law works is, as fast as something goes up, it goes down. So that can look forward to the same intensity that went up, the same intensity going down, which is nice. I'm just looking. New Jersey, is New Jersey peaking? I know New Jersey has been really struggling too, alongside New York, and I've been sort of worried about them. New Jersey peak is right now, yep, New Jersey is kind of mirroring New York City, very, very similar to New York City. And death rates are, again, pretty high for a city your size, around 230 or so, but falling as of yesterday, and let's see if it keeps on that trend. So things are, much like in New York, things are moving in the right direction. They're moving in the right direction for New Jersey as well. So that leaves us worrying about really Massachusetts, Connecticut, and Florida also had a similar kind of a late peak. So let me look at that. Florida is going to be almost 3 weeks before their peak fatality rate. They look like they're going to meet their resources and all pretty easily. But it's a pretty high hospitalization rate. So about 6,000 or so. Let's see. Will be interesting to see what actually happens with that. Okay. Looking at the restream again, seeing your guys' comments. I don't know what you mean by broken mice. I don't know what that means. Oh, I see. You're talking about I know. Yeah. This is not the time to have a conversation about the kind of mice that we do studies on. These are now, I'm talking about medication that is used on human beings. So not research, not bench research stuff. We're not talking about that right now. You'd think you'd have some data about given the excitement of hydroxychloroquine. You'd think you would have, we won't have data because it takes years actually to do these studies properly, but you would think we'd have some preliminary sort of hints at what's going on. I would hope that from an ethical standpoint, the researchers would have the ability to give us a couple of nods. Like, is this a good thing? Is it a bad thing? What direction is it going? Okay, so point is, though, things are looking pretty good. The numbers are getting adjusted down. Everyone needs to congratulate themselves for the monumental effort they have made to squash this thing, and it is clearly working. And I'll be interested to know why LA County is nervous, because I think they should be confident going forward. But again, I don't have the access to the data that they do. And again, in California, 40 million people. Somebody quoted me this morning. I thought it was 30 million, but somebody said it's 40 here in the state. We have 19,000 positives, 514 deaths. That is pretty damn good, which is why they're trying to figure out why it's so good. Stanford's trying to figure that out, looking at the possibility of herd immunity. You're going to hear more about testing going forward. I'm hoping in the press conference this afternoon, Dr. Fauci or Dr. Birx gets a little more explicit about antibody testing and viral testing and how we're going to roll that out. That's how we're going to be able to go back to work, is by testing all of that and seeing and isolating cases where they exist. And then the therapeutics. A lot of what this week has been about things like Dr. Yadegar was talking about is the application of these new therapeutics. He was telling us anecdotally he's having marked success in getting people off ICU, out of the ICU, off ventilators, and into recovery. If many other doctors are having similar experience, we will start to see that in the data probably the next time it's adjusted. So, Susan, anything else from your standpoint?
No.
I want to remind everybody that the Urban Resource Institute is one of the oldest and sort of deepest resource in the New York area for people facing domestic violence, people needing secure housing, people that have developmental disorders, and particularly during this COVID outbreak, they're also helping purchase food, protective gear, disinfectants, cleaning supplies, that sort of stuff. You can be a part of the solution at the GoFundMe link at my website at drdrew.com/URI. That stands for Urban Resource Institute. drdrew.com/URINYC. And anything is appreciated there, and the money goes quite far. So we've been highlighting we'll continue to highlight other charities that we think are very good at what they're doing. Don't forget the Union Rescue Mission in Los Angeles, and also our friends at Patina. And we're tomorrow, the weekend, Susan, you want to give a little preview of who we're going to be highlighting?
I'm working on it.
We can't yet?
Yeah, I mean, I'm going to have the people from URI on, and then also I might have Hillsides here, and maybe David Sheff.
Okay, David Sheff, of course, beautiful boy author.
We're going to talk about addiction.
He's also got a fund coming up where he's helping out with COVID, so he wants to talk about that. And also, Hillside Home for Children is a great charity we've supported for years and years and years. And
can you imagine what that's like right now?
Hillsides?
Yeah, having all those kids like in quarantine and having to keep them. They have like 70 kids on their campus.
Yep.
And they're also, dealing with the homeless situation as well. They're in their wraparound services, and it's just crazy.
Paul, you keep asking why the peak in Massachusetts keeps getting pushed back. I don't know why. I just know that it is. I'm not there to look at the local data and see what's going on. So maybe you can dig deep and tomorrow let us know. Can you have Dave Navarro back?
Yeah, I love Dave Navarro.
Yeah, we love Dave Navarro. He's welcome back.
I wonder how he's doing.
I'm sure he's fine. So in any event, we're going to kind of wrap things up. We're going to do multiple streams over the weekend. Is that true?
Yeah, I mean, I got a little pushback from our publicist. She didn't want us to work on Easter, but I thought we could still do one on Easter if anybody wants to.
Okay. I thought I wanted Reverend Bales to do a little service. I think that'd be cool.
He's a little busy, honey.
Yeah, he is. I know.
Let him
right.
let him take care of the
Happy
homeless.
Good Friday, everybody. Happy Passover to the.
I mean, we can just turn this on. We don't have to have a guest if they don't want to come on Easter.
All right, fair enough.
I mean, we're here all weekend, so, and then we'll have an Ask Dr. Drew on Monday with callers around 2:30 p.m.
And
We're still working on that. I have a couple of ideas. I was thinking maybe we should have some dentists call in and talk about what they're dealing with.
Also, they have charities too that they want to talk about once things get going again.
I don't know. I just can't do it until the day before. Everything changes so radically. I don't know what. Yeah.
Yeah. What did you say?
If I booked somebody a week ago, it would be like, we probably weren't going to have them now. Things change so radically.
Somebody asked how Oregon is doing. You're about 2 weeks from your peaks. The peaks are varying quite a bit, but you're generally you don't have a lot of cases. Oregon's in really pretty good shape generally. It's going to take a while to wash out. It's going to take about 2-3 weeks to peak, and you're going to be out of it more like the end of May, while many other places are going to be sort of finding their way out in the beginning of May. And again, that's why I don't know how they're going to come up with a national policy for how we get back to work. That's going to be very, very, very interesting. But I'm looking forward to it. I'm hoping Dr. Birx and Dr. Fauci hint at it today. They've been talking around it a little bit, but been very unclear about it. So we will see. All right. Sly wants to know why Black African Americans are being affected so much more profoundly by COVID. It is because of the healthcare disparities that those of us that work in medicine know about and have been struggling with forever. So there are higher incidents in lower socioeconomic, people of color particularly, Black or brown, of diabetes, hypertension, obesity, and some of the attention to some of the other chronic medical conditions is not as thorough as we would like it to be. And so this sets people up for the complications of COVID. And I think the other thing, if you look at the data coming out of New York, the living environments are having a lot to do with this. As I've said, unventilated hallways, tiny elevators, lack of warning for these folks about what was coming. They didn't know this was coming. And, and dietary indiscretions that lead to the blood sugar being up and other issues. It really is disturbing. And I'm hoping we look at this long after the outbreak
Don't they also
subsides.
have a higher rate of cancer?
They do, and
So people
dying
with
dying younger of all causes. And there's lots of theories. I mean, you can wave a wand and go, oh, it's systemic racism. But believe me, scientists have been looking at this forever and trying to figure out why. I will tell you, in California, our Surgeon General was just beginning a program on adverse childhood experiences. And the one thing we know about people that grow up in poverty is they have way more childhood trauma. I mean, there's so much more that happens because of the stress of the living environments and the poverty and the domestic issues, that children have multiple ACS, it's called, adverse childhood experiences, and that predisposes to all kinds of medical problems. And our Surgeon General here in California was just getting at that when COVID broke out. So I hope we will get her again to really focus on ACEs, because I think when you get right down to it, that is the issue that creates the problems in adulthood. So we will see. And
education,
no, it's not even just that. It's the trauma. And if you can blame however you want on why that trauma is occurring, in the medical profession, we have to start dealing with that trauma, because we have not been. Okay. Yes, our Surgeon General does rock money. She does. So does our federal Surgeon General rocks. I met him. He's a great guy. He's an anesthesiologist. And our California Surgeon General rocks, who is a friend of his, apparently, something I just found out. And I look forward to her doing great things. I'm going to get behind what she's up to. And given that Governor Newsom is moving so rapidly, seemingly, on the homeless thing, if that continues to go well, I can focus on something else, like our Surgeon General's ACE initiative. Happy Easter, everybody. We will be back again tomorrow. We appreciate you coming in. Thank you to Dr.
Happy Good Friday.
Happy Good Friday as well. Thank you to Dr. Tom Yadegar for coming in and for all the hard work he's doing. And we will continue to try to keep you abreast of what's going on. And we'll be back tomorrow. See you then.